Medical Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is Pfeiffer Syndrome. Now, to talk to us in a little bit more detail about what this is, what are its clinical features, the diagnosis, treatment, planning, we have with us today Dr. Roshan, who's a medical genetics consultant who's currently practicing in Trivandrum. I welcome you to Medical Dialogues Rare Disease Show. It's really a pleasure to be having you on board here with us today, sir.
Thank you, Nandita. I think we had met last time also. Thank you for having me again on your show.
Great. So now we're talking about Pfeiffer Syndrome today. That's a topic of discussion. So if you could just explain to us what is the Pfeiffer Syndrome that we're discussing today, and if you can just also highlight the key clinical features that actually should raise a suspicion for a clinician for Pfeiffer Syndrome in a newborn or an infant.
So basically, Pfeiffer Syndrome comes in the larger spectrum of diseases that we call craniosynostosis syndromes. So what happens in this is that when do we suspect such syndromes? When we have an abnormal head shape. So many times we see that the babies that are born will have an abnormal sort of head shape. Many of the times it is normal also, but sometimes it is so abnormal in shape that it starts affecting the other organs. It starts affecting how the eyes are placed, how the brain grows, and all those things. So this happens because when we are born, we know that the bones in the skull are not permanently fixed. They are separated by sutures. So why this is there is because as the brain develops and it increases in size, we want the cranial wall to expand, and that is why we have these sutures which will expand over time, and it subsequently, after once the brain growth is almost set or it plateaus, and it starts ossifying or it starts joining permanently. But sometimes what happens is that at birth itself, these sutures are prematurely fused. In such cases, when the brain develops, and even in the prenatal period also, when the brain develops, the brain does not have the space to expand well. Even the eyes and other facial organs also do not have the adequate face as a normal case, and this leads to an abnormal face and head shape. So these are craniosynostosis syndrome. There are lots of different craniosynostosis syndromes, especially those related to FGFR2, and Pfeiffer is one of the rarer of those. So when do we suspect it is that we have this obvious craniosynosis, that is the abnormal head shape is there. We see that the sutures are prematurely fused, and also some other findings, especially the thumbs and feet. They are abnormally placed. In such cases, we usually see or we usually suspect Pfeiffer syndrome.
Understood, Dr. Roshan. Now, at what ages do the most critical complications typically present and also require an intervention to go about?
Yeah, so this Pfeiffer, just like other craniosynostosis syndromes, usually at birth mainly has a cosmetic effect. That is, on looking at the baby itself, many times the face and the head might look disproportionate, but that does not have much of a clinical implication. But in certain cases, when it is severe, one of the major things that can happen is that because of the abnormal head shapes, our airway or our breathing canals and all can be compressed or can be abnormally placed, which can lead to either breathing difficulties or stridors, or in case the baby needs some resuscitation or so, we might not be able to perform intubation or any other such procedures in the baby. That is one of the initial features that they might be having. Similar to the breathing canal, breathing difficulty, they might have swallowing difficulty also, because the esophagus and the esophagopharynx and all might be a little abnormally placed than in a normal baby. So that is one of the things that we usually see in the neonatal period. Then later on, what we see is that as the brain starts developing, like I told, the whole purpose of these sutures is so that they can expand when the baby's brain develops. But when the baby starts developing or the brain starts developing, there is not enough give, or there's not enough giveaway of the cranial vault, and this leads to the increase in pressure within the brain, and this can affect the vision. This can lead to raised intracranial pressures. Baby can go into have seizures, encephalopathy, and in very rare cases and severe cases even lead to life-threatening complications also. So that is there in the infancy, maybe till around 2 or 3 years of age, till also till that around age also, this is a real complication that can happen. After that, in around childhood and all, mainly the facial dental malocclusions might be there. They are at a higher risk of having this recurrent ear infections also, that might also be there. Later on, many people will again have, as the child begins to have his own peers and friendships and all, their bullying and teasing and all creeps into their life, and many of them actually have psychological and psychosocial issues also, that also needs to be taken care of. And many procedures are there to improve these cranial abnormalities, and many of them undergo these procedures also around this time for the mainly for the cosmetic issues.
Okay, okay. No, now, which genes and the type of variants are most commonly implicated in Pfeiffer syndrome? Any particular genes? You
Yes.
had mentioned something about it in the introduction, so if you can just elaborate that a little bit more.
Yeah, so this again, fever becomes a part of a larger group of craniosynostosis syndromes, and FGFR2 is a gene which is notoriously associated with them. If you see the different syndromes associated with FGFR2, it is a huge list actually. One of them is fever syndrome. Many of them are other craniosynostosis syndromes also. So in fever, particularly in the FGFR2, if there is in the exon 3, usually if there is a gain of function, that is, if there is an increase in activity of that gene, a mutation which leads to the increase in activity, then we see that it leads to fever syndrome. But one more thing that we need to understand here is that the variability of expression. Sometimes we see that same person, same family, multiple people will be having the same mutation, but some of them would be very severely affected, some of them would be very less affected. So other than the genetic basis, there are some other environmental and epigenetic factors are also at play here. But from the genes perspective, it is FGFR2 which is mainly associated, but also fever also is of multiple types. FGFR1 is also one another gene that is implicated. Multiple genes are also being played, but FGFR2 is the main culprit that we see here. Yeah.
Okay, okay. Now, what is the preferred genetic testing? Now we've talked about its clinical features, what it is, how presentation needs to be addressed. So, coming to the diagnostic aspect, considering you're a medical genetics consultant, if you can just let us know what is the preferred genetic testing strategy for a suspected case, be it a single gene testing or it is a panel or an exome or trio testing. Which testing method would you usually prefer?
So we don't usually go for a single gene testing. We don't because mainly it's easier to say when we are just discussing about fever that we have to check the fever exon 3. But when an actual patient walks into your OPD, then it is difficult to say if it is surely fever or maybe some other overlapping syndrome. Like I told, FGFR2 itself is associated with so many different craniosynostosis syndromes, and it has overlapping features with others also, other genes also. So we could do a single gene sequencing, but the yield in a particular case coming to your OPD might not be that high. So we always would like to send a single test which can have the highest yield. In that case, an NGS panel is also fine, but nowadays we find that NGS panel and the whole exome sequencing does not differ much in pricing, but it adds much more in the future. If you want to reanalysis the data, new gene has been discovered, so the data is much more robust or much more future proofed in cases of whole exome sequencing. So what we usually do is that we directly go for a whole exome sequencing, and if it is coming up as a doubtful report or a negative report and we still think of a syndrome which is a craniosynostosis syndrome, maybe a whole genome sequencing or even a trio exome might be useful. So but if a patient walks into your OPD, you are suspecting fever or any other craniosynostosis syndrome, I would do a whole exome sequencing, and I think that is a standard practice across our specialty. Yeah.
Yeah, okay. Now, how do you approach the variants of uncertain significance in the FGFR genes for critical decision making. Now, is there any particular standard protocol that is being laid out when we have to think about Pfeiffer syndrome and FGFR2 gene that you were stressing?
Correct. So this variance of unknown significance is not only with fever or craniosynosis or FGFR2. It is a universally accepted program across the world, and we don't have a single best answer yet. So the best way to do it is to have a functional study. That is, we induce the same mutation in vivo, which in an animal study or in a we induce it in a zebrafish or in a Drosophila fly and see how it affects the animal. But that is not a very scalable or not a practical solution for every VUS that we come across. So what we usually do is, since it's a dominant disease, if the parents are unaffected, then a segregation, or if the parents can test and find that the same mutation is not in them, then we can add a de novo score to the ACMG classification, and sometimes we can turn it into a likely pathogenic. Other than that, we don't have enough specific or a one-stop solution to interpret all the VUS. So that is a universal problem, and it will take, I think this problem will persist for at least next few years until we have a scalable solution for this. So what we do is that we match the phenotype with the patient. So it's called reverse phenotype. If we have an FGFR2 mutation, we will match what the child or the baby is matching into, and we'll try to reverse phenotype. That is, whatever is the finding in baby is it there in the disease, and whatever the finding is there in the disease is there in baby. We check it. We call it as reverse phenotyping. That is one thing that we do. Parental segregation, like we told, is another thing that we can do. And literature reviews, a lot of times these automated tools will not be picking up all the literature. Maybe if we do a manual literature search, we'll find some more additional evidence which can help in US reclassification. But a lot of times what happens is that we will not be able to give a final answer to the patient or the others, and we'll have to label it as a VUS only. Maybe we can reclassify it yearly and see if some additional additional evidences have happened. So standard practice here is that we do one more thing. We do a step further, and we try to find any research groups who are working exclusively in the gene, and we would send them the variant that we have, and if they can provide some additional light on it, we will accept it. Otherwise, again, we'll go back to the default, that is wait and watch. We'll just add it to our list, try reclassifying once a year, and hope that someone somewhere else has reported this variant, or some additional functional study has happened elsewhere, and we can use it for our variant reclassification. Yeah, that's what we are doing currently.
Okay. Now, what specialists, now if we're talking about a multidisciplinary approach for the treatment aspect, so what specialists should be part of this core multidisciplinary team who are managing Pfeiffer syndrome?
Yeah, so again, as a geneticist, we only take care of the holistic view, or the overall management of the patient, and we do the genetic testing. We provide family screening. We help them establish a surveillance protocol and make sure that it gets done. But most of the features managing, we are not doing. We have specialists for each of the field that we refer them to, and give them our opinion on how they have to be managed. This becomes especially important during surgeries and all, when the anesthetist needs to know what sort of complications can happen in these cases. So we give them our inputs, and that is how they manage. So the bottom line is that we don't manage, or as a geneticist, we can't manage these patients alone. It's a huge multidisciplinary team that we need, who would be taking part in this, and ensuring the overall health, or overall quality of life of these patients. Obviously, first we have our geneticist and counselor who would be counseling the family and even the child when they grow up. But after then, a lot of times we need a neurosurgeon, especially like we told earlier. There might be a raised ICP might be there, and it's a life-threatening condition. Sometimes we have to open up these sutures for the brain to develop. Again, a neurosurgeon is very much important there. And regarding the cosmetic function, and regarding the proptosis, or the eyes which are which might be pushed out in some cases. We might need a OMFS surgeon who can help with that. And many times, if there is an airway issue, we might be able need to intubate or tracheostomize the baby. We might need an anesthetist or an ENT specialist in emergency cases. Ophthalmologist might be needed, and especially as they grow, these children will have dental malocclusions. They have ear infection, so they will need the help of a dentist and also an ENT surgeon. And obviously, as they are growing up, a pediatrician would be needed, and at the later stage, most likely they will need some psychological support also from a psychologist. So a huge team has to come together to manage such complex cases.
It's actually a multiple effort that actually comes and is going to benefit the patient in the long run. Now, what are the current best practices for airway management in infants with midfacial hypoplasia and even craniostosis? Now we're talking about that. So, are there any best practices that you can quote?
Yeah, regarding the best practices, this remains same for a lot of syndromes, including these syndromes. The main issue, these children can have issues in two ways. One is before surgery; they are otherwise normal, but they are scheduled to have this neurosurgery or craniofacial surgeries, or maybe a hearing or a dental or a facial surgery, and they might need multiple surgeries, and at that time airway has to be maintained. So that is a different thing, and we work closely with the anesthetist team to discuss with them regarding the issues that can happen during the airway, and the difficulties that can happen during the intubation of the child, and also regarding the also regarding the spinal instability that these children might be having. So we work with them, and each child is different, so there is not a single best practice, but we have a overall set of things that we do for these children in association with the anesthesia team. That is one. And the other is not during surgery, even at the birth or maybe as the child grows, they might have some obstructions in the airway or the upper or the lower airways, and they can have this respiratory difficulties. So if it is a very acute case, or if it is a very severe or a life-threatening situation, we might have to directly go forward with the tracheostomy. So a ENT surgeon or a critical care surgeon, critical care specialist is needed in that cases. But if it is only a subtle or a subacute or a chronic or a mild thing, maybe what we will do is that we will try some CPAP for them to use at home, or maybe a continuous oxygen supplementation, and see if they are improving. If the mild can be measured, the mild ones can be managed just by some CPAP at night, or no, and without the need of any tracheostomy or procedure. That is the best thing. But if it is needed, we might have to tracheostomize the baby. So that is what we have seen.
All right. Now, sir, what role do now you mentioned about a multidisciplinary team? So, if non-surgical therapies, what role do they play longitudinally? If I talk about, say, orthodontics, now speech, hearing support, physical therapy, you just mentioned that all these will be needed as you're talking about the airway management, the protocols that you just laid out. So, what role do these non-surgical therapies will play eventually?
Correct. So one of the major things that we might need is the dental support, because almost all such children would have dental malocclusions, and a lot of times you won't need surgeries to correct them. They can have braces, and it can be, if we do it early enough, we can manage it, and that is one non-surgical therapy which most of these children would need. And the other is, many times what happens because of this abnormal facial structure, they might have speech difficulties. They will need speech therapies. Usually they don't have some major development delays, but some of them will have, especially if they have had the episodes of raised trachea impression and all, they might have some development delays. They will be needing physiotherapies, and at a later stage psychotherapy. Like I mentioned, these cosmetic issues and their psychological issues might pop up during their adolescent ages, and many of them would need this psychological support also. So these are some of the things that we usually see in children with fever.
Okay. Now, lastly, sir, what are the long-term neurodevelopmental and functional outcomes that you typically observe in such patients?
Yeah, so uh, whenever we talk about any genetic syndromes, so the outcome depends on a few things. One is if it can affect the development, or would there be any intellectual impairment in such children? Would there be any long-term complication needing multiple, or affecting their daily life, or something? Is there something that can be life-threatening? So in children with fever, in this case, if we see against this measure, they usually won't be having any intellectual disability per se. So if we manage all the complications, they would go on to have a good development and a good neurological outcome, provided the raised ICP complications are well managed. So what we do is that from the birth itself, we start them on surveillance, and at any point, if we think that these children are going to have some raised ICP or early features of raised ICP or early fundal changes or eye changes, then we will start them directly on surgery or some preventive measures. So if we can manage them, the neurological development is usually fine. But the other things, the skeletal deformity, the facial deformity that are there, that although cosmetic, can significantly affect the quality of life in a person's life. So that a lot of surgeries are there, a lot of multiple procedures are also there, but can be completely reverted to normal? Maybe not. So some residual facial features might be there, and how it affects the person psychologically, it would vary from person to person. So otherwise, if we manage the raised ICP and we can have the psychological issues under control and start them on a good surveillance protocol, most often these children do good. That is the case with most of the common craniosynostosis syndrome. Although they have this cranial anomalies and all, usually if they are managed well, they have a very good quality of life. So that is one of the good things about this spectrum of diseases.
That's actually great, sir. Now, lastly, if you can just describe any challenging case that you've managed, or the lessons that you've learned from multidisciplinary decision making in such situations.
Yeah, so in fever, we have not had any challenging because it's a very rare syndrome, even for a cranial syndrome. Much more common is a Cruzon syndrome. So Cruzon syndrome is a syndrome very much similar to fever. They won't be having this thumb anomalies and all, but they will be having these facial anomalies similar to this fever. So in cranial syndrome, also a fever-2 related disease. In such case, we had a case where baby was brought to us. He was having the typical features of very severe Cruzon syndrome, and we did the testing and we proved it. But the thing is that when we saw the parents, I think the father was also, and father's mother, they were all looking similar, and they tell that there are a huge number of people in their family, in their extended family, who are also affected with the similar facies. So the problem came when they were planning the next pregnancy. So we told them that the problem came here because the parents and the other extended family members were having very mild features, right? So they have not considered it as a disease. But the same condition had penetrated much higher and has formed a very severe disease in case of this baby. So the problem came when they were planning the next pregnancy. We don't usually tell them whether to do a prenatal testing or not. It is the couple or the parents that has to decide. So we told them that the first baby is having the same variant but a very severe phenotype. It is not necessary that the baby will have the same severe phenotype at all time. The baby might be having a phenotype similar to the father or the grandmother or the countless number of other people in their family who are otherwise normal. In this baby, actually, the first severe baby, we had to subject her to tracheostomy, and also this IV shunts and all had to be placed. So the parents were worried that the next baby will also meet the same fate, but we counseled them that the penetrance is different and it might be normal or near normal like the parents in them. And actually what happened is that the father's family were telling that it is a normal condition, we don't want to go for a prenatal testing, but the mother's family were on the other side and they wanted to test the baby for the condition. And at the end, we actually ended up testing the baby. But these kind of challenging cases come especially because the penetrance is variable and not predictable. Some children might be having the same mutation and a very mild phenotype, but some of them would be having a very severe phenotype. So it is challenging to deal with such cases. Yeah.
Great. So, thank you so much, Dr. Roshan, for sharing all your details on Pfeiffer syndrome and explaining to us about this in little bit detail, so that there are more and more healthcare professionals who can actually narrow down and help them diagnose this if a
Right.
child presents to them at their centers. So, thank you
Yeah.
so much once again for joining us today at Medical Dialogues and giving us all your insights on this.
Thank you, Natita, for having me.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.